Hello there, and welcome back to The Price of Pain. For some reason, it feels like we haven't done this in forever. I know you just had an episode 2 weeks ago, but for whatever reason, I feel compelled again to just say how excited I am to be continuing this in 2022, and so happy and grateful for your support as an audience following along. Today's episode, we have Dr. Mark Bishop. He's an associate professor in the UF Department of Physical Therapy. And maybe more importantly, he's the director of physical therapy research, so he has a hand in influencing the curriculum and development of all the doctors of physical therapy that this program produces. We talk a lot about his background in physical therapy as a clinician in 3 different countries and how that brought him to a point where he could apply what he used and what he learned and the questions that were developed over that time to his research in the time since. It's a really exciting episode. I like all of our guests who exist in that intersection between pain research and the application of said research, and Dr. Bishop is certainly one of those guests. So sit back and I hope you enjoy this episode.
Welcome to The Price of Pain, brought to you by the Pain Research and Intervention Center of Excellence at the University of Florida. Let's join host Dr. Joshua Crow in conversations with scientists, healthcare providers, and industry professionals as we delve into the highly subjective experience of pain and the ongoing effort to reveal its influence on our everyday lives.
So there's this offshoot of an Australian accent, which has all of that, it's intellectual sound, but with some built-in approachability. So I think if nothing else, you could talk about the color of the walls in your office, and our listeners would still be pretty interested in what you have to say. Yeah. Particularly my aunt. I have to tell you this also. We had Steve Coombs on an earlier episode. She's like, "Oh, that's fantastic," and she says, "But what I really love is an Australian accent." I said, "I have a guy for that." So it has nothing to do with your publication track record or your role and your contributions to science. It's just so that my aunt can hear the accent.
It never does, mate. It never does. No, that stuff's all immaterial when it comes down to the end of it.
But I do want to talk a little bit about your background, though. You started your education in Brisbane, correct? Before coming here for grad school?
Absolutely. So Australian education at that time, PT was a bachelor's degree, so went straight in from high school to the University of Queensland and ended up, so I worked a couple of hospital jobs, mainly in the southern part of Queensland, Gold Coast Hospital, and then some private practice work in northern Queensland. And after that, left and worked in Canada. So probably 1991. I got to the great good fortune to work with a set of private practices there. One of the practices had the contract with the Calgary Flames, and so that was a big practice. And then the practice I worked for did junior AA hockey.
I never knew that. Okay.
Yeah, so I worked at McMahon Stadium, physical therapy. They had the rink right there. The guys had come up and work with the sports physios to get their stuff taped and their recovery things. And there was a third practice that had the contract for the Stampeders.
Okay.
And Doug Flutie was playing for them at the time. So that was a lot of fun. That was a good time.
Now, I don't always get the opportunity to learn something new about our guests. Some guests I'm really familiar with and some not. But that, you're kind of in that middle ground. I had no idea. So, looking at that in comparison to where you are now and what you do now, it's a little bit understandable that you research pain and physical therapy. If you had your beginnings, at least stateside or in North America, at least in hockey. So, how does did you get the opportunity to practice at all in the States or just Australia, Canada?
So after I left Canada, my visa ran up as it does, and. We were headed to South America for the South American leg of the World Tour, but ended up getting work in Florida. Started for traveling healthcare. I don't know if you're familiar with those type of companies. So,
like the same as traveling nurses, where you
absolutely
would, okay,
absolutely. This was for physical therapists, and got one of those jobs. Ended up working for a hospital here in Gainesville, and then for a private practice in Gainesville, then a different private practice. I eventually met somebody, got married, decided to stay here more permanently than a traveling contract. And here we are, whatever it is, arrived here in 1993.
Now, looking back, obviously, a little bit, but how does the practice of physical therapy compare between Australia, Canada, and the States? Similarities and differences? Or is it pretty much all the same?
I'd say the actual interventions and things like that, very similar. Using all the same sort of skills. Maybe we differ a little bit on emphasis. The Canadians with whom I worked were, a lot of them used a lot of exercise, and manual therapies were something that you did after you finished PT school. You went on and did additional training. And in Australia at that time, it was part of our PT school, so I guess my focus was a little bit different. I tended to go to manual therapy earlier as an intervention. And then United States, same sort of thing, probably more similar to Canada, I would say, that at that time when I came to the United States, people would learn manual therapy and do it, but it wasn't quite as widespread in the entry-level education. Lots of people did it as a post-professional training. The biggest difference, of course, is the healthcare systems.
Yeah, elephant in the room, right?
Yeah, and so how you interact, the number of times you interact, and with whom you're interacting was quite different. I have not practiced in Australia or Canada, Australia since the 80s and very early 90s, so I'm sure things are tremendously different, but,
And one of the reasons I asked is because throughout my PhD, there were some things in the lab that we wanted to research and that we sought to get funding for. Near-infrared photobiomodulation, for example, and some things like this that the publications to support that for evidence-based practice seem to come from either Australia or South America. But studies in North America either didn't have interest in that or weren't funded by the NIH. So I was just, that I was wondering if there are other, types of interventions and therapies that, or therapeutic modalities that you could employ there that you couldn't here, or vice versa.
Yeah, I'm sure there are. I unfortunately haven't practiced there, so I'm not really sure what the changes have been. I know one of the fairly large differences between practice in Australia and the United States is Australia has been direct access, meaning you can go and see a physio without needing a referral. I'm maybe 1972 comes to mind. So and the US has forms of direct access, not unlimited direct access. For example, in Florida, you can go and see a PT without a referral. Your insurance company should cover that, but if it's going to be longer than 30 days, then you would need to see a physician of record. So
was that one of the because you had mentioned that when you got your training, it was a bachelor's degree, and I know that it transferred from that into a master's degree, and now, and I'm not sure as far as the perspectives from the APTA, but now it's a doctor of physical therapy. It's a doctorate. Was that one of the driving features to push toward it being a doctorate level education? Is to maybe promote the idea that this is a level of healthcare that should be direct access, or are those two things totally unrelated?
No, you're on the right track. There was a vision that the APTA had to elevate the professional reputation, professional status, as well as professional skill in the United States. And one of the ways that they saw to do that was to transition through to clinical doctorate. There were other goals as well. But every program in the United States now, if you complete your professional training, you would graduate with a doctor of physical therapy.
What are some of the ways that the education has changed to elevate that level of degree? from at least just from master's to now it's a 3-year, correct? It's a 3-year program. And I do have a little bit of knowledge of this because at one point I was considering, PT school or PA school or PhD, and have, throughout my doctorate had a number of students that were undergraduates that were preparing for PT school. So I learned a little bit about it, but I'm still somewhat naive as far as how that's changed over the past few years.
So I think, excuse me, probably the most common addition to a master's curriculum that occurred is programs added coursework with more emphasis on radiology, imaging, I suppose, pharmacology, and differential diagnosis, some of these type of courses. And every program, of course, changed things a little bit differently, but I'd say those extra areas of training and focus were considered important to make sure that we could be considered a doctoring profession. People modified their clinical experiences and clinical training, and so I should know all this stuff as program director. So I the programs are about somewhere between 2 and 3 years. Very commonly, I think, around 2 years in a semester, 2 years, 2 semesters.
And one of the things that I think makes you unique as far as a guest on the podcast is, and we discussed a little bit of this, before going on air, but you have a clinical background in treating people with pain. And as you mentioned, it's been a while since you practiced. You've transitioned through research and are now in an administrative role also, and we can get to that later. But physical therapy seems to be one of the healthcare disciplines that pain in diagnosis and management and treatment of pain seems to be central to what you do. It doesn't seem, and again, correct me if I'm wrong, but it doesn't seem very common that somebody goes to a physical therapist and says, well, I feel fine, but something's not right. It seems like there's always a pain component. So how has your clinical background influenced or informed your interest in research and I know we're going back a little ways, but if you could think back to that, what were some of the things that throughout your clinical years you thought, oh, well, I really wish that I knew or somebody did, fill in the blank?
So I'm going to tell this story in a couple of different parts.
Is there we get an intermission in between?
Yeah. One of the parts is, so when I think about physical therapy as a profession or a discipline, there's many different places that physical therapists practice. And so some physical therapists may not deal with a person who has pain. But there's lots of physical therapists who practice where people have pain. They're in a hospital, they've had surgery, they've had a stroke, they've hurt their shoulder, they've had a sports injury, they have some sort of degenerative change, a connective tissue disorder. And as you say, most people aren't saying, you know what, I feel pretty good. Feel pretty good. Today's the day I see my physical therapist.
Right.
And as a profession, we've been talking a lot about pain and pain management as a profession for many years. 2016, we really, I think, this is just me, but 2016, the APTA started to push the Choose PT. We're looking at the opioid crisis, saying, you know what, PTs are perfectly situated to be doing these non-pharmacological interventions. And we've had a long history of support in medicine, the ACPA guidelines for low back pain in 1994, primary recommended spinal manipulation, manual therapy. PTs do that. And so we've had this long history of being recommended as a non-pharmacological intervention for pain, but perhaps not being sought, if that makes sense. And so they launched that Choose PT for pain. Florida launched PT for pain. And so I would say that maybe the last 5 years has had a lot more press and maybe pushing to advertise. And we've had some really good opportunities to participate around education related to non-pharmacological management of pain.
Mm-hmm.
So I think that's kind of, if I was going to summarize it, say why that might be something that people think more now than they did 20 years ago.
Mm-hmm.
For myself, this is Act 2. So when I was working here in Gainesville, I had the sports jobs,
Mm-hmm.
and I talked to the traveling healthcare company who said, yeah, you want a sports medicine job in the mountains an hour from the beach? You got it. Signed all the paperwork, waited for my visa to come through, and they said, oh, well, that sports med job in the mountains near the beach is not going to happen, but we do have this other job. And that was the hospital position, and I did that. I actually love acute care, so that was a lot of fun getting back into that environment after a couple of years.
And so that's a setting, if I may interrupt, that's a setting where you're going to the patients who are inpatient,
yes,
and treating them while they're in the hospital.
Absolutely. So
Okay.
People who are hospitalized for whatever health condition,
Mm-hmm.
and you're helping with mobility and activity and working with other disciplines like occupational therapy to think about how is Josh going to do when he gets home? What do we have to prep for?
I have to interject just one more thing, that I vacillate between being amused and offended by how physical therapists are represented in cinema, because it's always the kind of quirky, Birkenstocks, hey man, how you doing, casual. Usually the guy has a perm, and it's always an inpatient PT in those settings. And I don't know if I've ever seen a profession that's more misrepresented in pop culture than that. When you say inpatient, that's a hospitalist position. That's what comes to mind. Is always the kind of quirky, weird guy that the patient's always like, no, go away. But anyway, please continue.
Perfect. And so then I got a clinical job where I had to work with people who had low back pain.
Mm-hmm.
And I did not know what to do for someone with low back pain. It hadn't been part of my practice. I'd had the sports positions or these acute care hospital positions, and now I show up and there's 15 people on my schedule who all have back pain. I say, how can this be? What do I have to do? And so I guess that really kind of started it, because I didn't know what to do. So I started hanging out with some people who used to go to the library, and long story, took courses that eventually the university said you have enough credits, you need to declare a major and get a mentor and start doing this. So I don't want to misrepresent completely, but the first part of my graduate education was a little bit accidental and haphazard. I wanted to know more about how tissues healed, so I took classes about pathophysiology and healing. I wanted to know how something adapted to mechanical stress, so I took classes. And so that was my path to eventually getting a graduate degree.
And somewhere along the line, somebody said, hey, Mark, you're 3 credits shy of a master's degree. Why don't you just go ahead and do this? And then, because you have both a master's and a PhD.
That's almost exactly what happened with graduate school, saying, well, you're going to have to find a mentor, do a project, and like make this a degree. You can't just keep taking credit.
You can't, or you can't come back. That's enough. All right. Yeah, I guess in your role now, you understand how important the numbers are. You're looking like one of those that did not, a non-success story just by going and learning. Heaven forbid, But
Yeah.
all right.
So I was still working clinically. I took class at night and stuff like that. So I guess my last full-time job was the turn of the century.
Okay.
And I don't get to regularly practice. Thinking about this a little bit, I mean, I have the opportunity to practice every week. We have the pro bono clinic that we started in 2009. So periodically I will go and work with students who are learning, practicing, engaging with patients who are there, and so that would be my clinical contact right now.
How much has the practice of physical therapy changed from then till now? Are there major ways that it's different, or just small refinements over time?
Small changes over time. That if you were going to ask me how my practice has changed. A lot of it is related to documentation, billing constraints, but the people aren't different. The sort of process isn't different. Those things aren't that different.
You know, I've always wondered also how much, obviously, it seems to me at least that most programs, most clinics, most PTs tout an evidence-based approach to their practice, meaning that whatever therapy they're providing, there's something in the scientific literature that supports that it works. However, all people are different. So how much leeway is there in and I ask this because you're now in a role where you have a say in the curriculum and in the teaching within UFPT, correct? So how much leeway is there for adapting what's known in the literature to benefit a patient? Is that something that happens?
Yeah, so a couple of things. When you think about evidence-based practice, practice-based medicine, the evidence, you're looking for the best available evidence.
Mm-hmm.
And sometimes the best available is a rigorously controlled trial that gives you a specific answer about a homogeneous population. And so then the next step is to work out, can I apply that group data to my individual patient? How do I do that? And so that would be something that a PT student would learn. But a lot of the times, there is not that rigorous data. So you have to make a choice about what is the best available evidence. And this is something another opinion of mine that gets misrepresented a little bit, is that if I don't know anything about the condition and you have seen people with this condition, your experience is better evidence than me not knowing anything. And so in that situation, the best available evidence is your clinical experience.
That makes perfect sense.
Right? And so it may not be that it's strong evidence, but the best evidence I have is that you've worked with someone who's had this condition before, and this is what you did, and this is what you found. Because otherwise I don't have any evidence, and I'm just kind of making things up as I go along. So, you know, I feel like several professions, I can't speak for all, but I know it's not uncommon for me to hear people say, oh, well, there's nothing supporting this in the literature. And an absence of evidence doesn't mean an absence of effect. But I still need to weigh these things and say, actually, they did do a couple of studies where they showed people got worse. Okay.
That's
all right. So
valuable.
If I know that, then I don't do it. And there's probably lots more studies that show indeterminate effect, and this was about the same as something else. So then as a practitioner or a provider, I have to weigh that and say, so the three stools are the best available evidence, my experiences and your preferences. And say, Joshua, here's what we know. Here's what I think. What do you want to do?
Yeah, that last question, that last component was a big selling point for me. And I try not to talk too much about myself on this podcast. But as you know, I rehabbed after a quad tendon repair, pretty vicious quad tendon rupture, and then had it repaired to the extent that I could return to athletics. And so, of course, larger stress predicted in the future meant that he had to be a little bit more rigorous with this type of repair, the surgeon did. And that was both with my surgeon and with my physical therapist throughout rehab. And it was a long rehab. That was the question that really drove home, and it was here at UF, so I had high confidence in both of them. But that was the question that really drove home my confidence that everything was going to be okay. Both the surgeon and my therapist asked, what do you want to get out of this? So not just with the surgical intervention and the repair, but hey, how aggressive are we going to be with this rehab? What are you looking to do? And that came into play huge because with my therapist, this is one of those cases of lack of evidence. I don't fit the demographic for a quad tendon rupture. That type of injury is more prevalent in in an older population with comorbidities that I don't have. And so it was unique in that respect, my injury was, but also infrequent enough that there's just not a whole lot of literature out there on the best way to rehab that. And so I was put with a therapist who was awesome, that had, I think he had somewhere 4, 6 prior patients that were comparable to this over the last 15 years, I think he said. So it's, it was one of those things where in the absence of the literature, he had, these experiences and can say, well, you're kind of like this and you want that. But that leeway, I think, was huge.
Yeah, and I'm not suggesting that my experience trumps strong evidence.
Right.
But if I don't have that strong evidence, then I need to go with what I have.
So with low back pain, and then this is another thing that our listeners don't know, but when discussing my dissertation, you were the first exposure I had, direct exposure, and this is, as you pointed out, one of the weaknesses of my project, in asking, well, have you done any quantitative sensory testing? Have you done any pain testing of that? My answer at the time was no, because I had no idea what it was. And so that contact and those questions were my introduction to where I am now. So thanks for that.
You're welcome.
Well, I wasn't able to rectify, that shortcoming of my project. You just have to talk about it in the discussion when I eventually write it up and publish it, or at least submit it for a publication. But you're able to do something that some of the other researchers that I've had on the podcast, you're able to do something that they're not able to do, which is see some of the direct applications of a discipline, pain research, that's not very well known and not very well understood. It's a growing discipline. So what are some of the ways specifically with physical therapy that your experience in your research and your findings, you've been able to say, look, this is exactly how we can use this? Because many of the people on the show have very interesting and compelling work and groundbreaking work. But I have to think that our audience says, okay, that's great, but so, what are some of the ways that we can directly connect the dots here with some of the work that you've done?
Well,
That's a broad question.
It's a pretty broad question.
Let's start with low back pain, because that's a pretty large burden.
I'm going to start with a shameless plug.
Okay, let's do it.
That? So I've had the good fortune to have a bunch of collaborators who share similar interests to me as manual therapists, subdiscipline of PT, chiropractic, osteopathic, variety of different professions.
Okay, I hate to do this, but I have to act as a proxy for our audience. So when you say manual therapy, can you describe how manual therapy is? What are some of the?
Absolutely. So manual therapy is a broad term that applies to me performing interventions where I use touch. Usually, it's there's a force associated with the touch. Sometimes different types of manual therapy have different levels of force, different targets. I tend to be someone who's very joint focused, moving the joints passively to try and achieve a few different goals. There's people, you might be familiar with massage therapy or some of the myofascial release sort of thing. That's focused on a lot more of the soft tissues. So you have these broad disciplines that are using touch to create some sort of change with the end goal of improving someone's function, quality of life.
Okay.
And so we were in this phase. There was maybe 5 or 6 of us who were really interested in manual therapy clinically, who now were all working at a university doing research into pain, saying, we should totally use some of these things that we're using in these other studies that we're doing with our mentors and say, let's collect this stuff on the patients that we're seeing. And, there was the usual, I think, or common, not usual, common approach. Here's some studies in healthy people. All right, this is what we saw. Here's the studies in people with pain. This is what we saw. That's pretty interesting. And so that work in 2005 or something like that. So groups in the past had shown something similar, but our timing was right or something, because Steve George published a paper about getting hypoalgesia immediately after spinal manipulation, and we did a series of studies to try and tease apart, the parameters and the dose and all this type of thing. And then
so spinal manipulation reduced pain, or at least immediately after.
Immediately after reduced your response to standard stimuli, so your receptors were less sensitive. And so we showed that for a variety of different types of manual therapy and a variety of different parameters, so that we were therefore able to argue that, you know what, in my early training, it was a very biomechanical model, that the reason this helped was because I moved a tissue or I changed a position. And there was some fantastic work done in the 80s and 90s that said, well, yeah, you're moving it, but you're not permanently moving it. It's not actually moving the way you think it was moving. You're moving something else. And so we were able to compile a bunch of information that suggested that the way that manual therapy was probably working was at least in part through neurophysiological responses to the intervention. And we were collaborating with some clinical psychologists who encouraged at least some of our group to say, well, you haven't even thought about what people think and how that might influence it. And that opened another avenue to really think about how our manual therapy interventions were generating changes in pain in particular. Now, once again, we were not the first people ever to have suggested this, but Joel Bialowski, if you've ever run into Joel, one of his dissertation papers, kind of, I think, was the first literature. Someone's going to respond to this and say, "Hey, Bishop, that's incorrect." But it was a paper that must have just hit at the right moment when people were ready, because people had written about this before. Joel kind of put it all together in a model to say, you know what, this is probably how it works, and here's ways we can test how it works. Here's what would happen, which I think was a little bit different. And so that was a pretty important moment, and there's probably some people in manual therapy who are really annoyed at the University of Florida, but we had a consistent period where we've been really able to kind of promote this idea that it's not just the biomechanics, it's the neurophysiology. Joel's published a couple of other updates to the model, and then we've spent some time thinking about particularly expectations that the patient has and how those interact with the expectations that the provider has, and how that can really maximize the outcome of a conservative intervention for pain. So this was a long way of kind of coming back to how my clinical background informed at least this part of the research. It was directly related to stuff that we were doing clinically to say, well, let's see if we can work out how this is happening or why this is happening. And we were very fortunate to be able to be in a place where that could happen.
It's, as you're telling that story, it strikes me, whether it's with Bialowski or George, there are parallels between science and music, where you may not be the first one to do it, but when you did it at the right time, and the right people were paying attention, in music and in science, you maybe published in the right journal that got the right people cited it, and it blew up, and at one point, I think that's really for an early stage investigator like myself. It's encouraging, but also discouraging that you could get that out there and then some gets lost in the shuffle and nobody really latches onto it and furthers that work. But nonetheless, so how does that play into then the biopsychosocial model that so many of us in pain research rely upon to explain some of these effects? Where in the development of the biopsychosocial model did that come in, and were you aware? I mean, did that kind of help you to say, well, these are some of the things that could be contributing then to these effects as opposed to just the manual therapy?
Yeah, I'd say that's a pretty accurate sort of statement. As a PT, particularly in the US, we frame just about everything in the ICF model from the World Health Organization and use part of the biopsychosocial framework. Mm-hmm. And it certainly for this manual therapy, it wasn't part of our initial thing. We were just observing what happened in the nervous system when we... I mean, it was pretty primitive. I'm going to push on this and see what happens. And so we pushed on that and saw what happened. Mm-hmm. But then, particularly, Steve George worked a lot with Mike Robinson. Mm-hmm. And so Steve George is PT, Mike's a clinical psychologist and clinical and health psychologist. And so they had some really good collaborations going, thinking about, what is the interaction between the physical and the cognitive, affective, so the psychological. And then, we've also kind of added some of the social, I would say, in part of environmental context. So the environmental factors influencing a health condition and your recovery from that condition, social support and some other things like that. So, I'd say it all fits in there pretty nicely.
Yeah. So let's focus in on low back pain for just a moment, because a lot of people have a problem with this. And I was just having a conversation with a family member recently who's still struggling to alleviate the pain she experiences and has experienced for some time with her low back pain. What are some of the more salient ways that you've found you can augment therapies or specific therapies that alleviate or at least help to manage low back pain? Things that maybe at one point were a little bit outside the box, but because of this research, you've been able to kind of reintegrate some of the things that you've studied back into the practice itself that may, even if it's just to enhance modalities that already existed. Are there some things that stand out in your mind?
Well, so if I go back to the start of this particular story, one of the things there's lots of different ways to classify someone's sort of why they're having back pain. Mm-hmm. And in one of those ways, there's a particular set of characteristics that suggest someone is going to respond well or have a good prognosis, however you want to frame it, mm-hmm. after they receive a spinal manipulation. And that's what kind of got us started, say, why does this work so well for these people? Let's check it out. And so there's certainly ways to look at that, and we get 5 PTs, 5 chiropractors, you've got 10 different philosophies. However, once you start going through and looking at the commonalities across everyone's slightly different philosophy, that there's those characteristics that suggest someone should do well with manipulation. There's characteristics that say, okay, these people tend to do better with exercise that helps control the spine, mm-hmm. and so on. And so, my recommendation is go and see a good physio who has worked in the area for a while and say, let's see if we can take this picture and say, what sort of class or category of group of exercises are going to be beneficial for you if you have acute pain. And the challenge with people who've had pain for a long time, as you know, is there are a little bit more difficulty in getting that to resolve. Chances of complete resolution are not as good, and so you're beginning to face some other sort of things. But there's some, let's say, fair. I was going to say weak, but that's not going to be very encouraging. There's going to be some...
Y'all are out of luck, sorry.
Yeah, there's going to be some interventions that actually have better effects if you do the intervention than not doing the intervention. It's just not a great big effect.
Yeah.
And the good news is that when you start putting interventions head to head, the effects are all better than doing nothing, but it's really tough to say this is the best and this is the best. So lots of recommendations for how to put those things together, but I know that doesn't answer your specific question, but I would start by going to see a good physio.
Yeah, but that's good. Somebody who is up to date is aware of how these different interventions are, I guess, received by different populations, and see which of those populations best fit you. How do you rectify within the field, of course? Now, this is not as a PT, but in education and whatnot. You mentioned earlier on our healthcare system, and there are limitations on how much money and how much time you can spend in therapy before the time and money runs out. And so, and this is not specific to low back pain, but just to the discipline in general, for people who require more time or long-term intervention, specifically in chronic pain populations, where that may not alleviate all of their pain, but helps them to manage the pain to a point where they can remain functional. How do you rectify that finite amount of therapy that they can get with how much they actually need under our current healthcare system?
Right, that's a big one right there. That correct question. I mean,
when you sit in the big chair, when you put that director title in front of your name, you get those big questions also, though.
Yeah, so this is certainly a conundrum that has to be balanced, because let's say you're in PT school and we've spent 2 years talking about this is the best intervention for this condition, but no one's going to pay for it. I mean, that could be considered a pretty serious ethical dilemma, that I now have to offer you a treatment that is not the best. Fortunately, that's not the case for everything, but it's definitely part of the problem for some things. That if I have a chronic condition, I've had a stroke or a spinal cord injury, I have a chronic pain condition, that I need a lot of treatment. And as you say, the system is not always set up to support that. And so, that's why I think you see in a lot of US sort of health systems that they'll call them a step-down unit, and maybe you and I work together. So you know what, we're going to spread this out, we're going to work together for 2 weeks, and then you're going to do this by yourself. And there's lots of that negotiation that happens that may not happen in, say, the Netherlands or Australia, whose health system is very different. But it is a constant weighing of that, because if I don't get paid for providing care, I can't provide any more care. And so I have to make those sort of decisions about where I'm going to charge, how that's going to look. And some people may not accept certain types of insurance. I don't know if that's ever happened to you, but say, well, the reimbursement isn't quite enough for us to cover the cost of having you come. Now, I have the great good fortune of working at a pro bono clinic once a month, and so I don't face that. But it is something that is problematic, certainly in our profession. I think probably in other professions, and there's lots of advocacy efforts that are going on to try and keep the therapy cap consistent and not be cut. And working with insurance companies to come up with different sort of ways and payment plans?
Well, I think most people who've had any kind of exposure to physical therapy understand that when it comes to exercises, when it comes to things that can be done, you can inform them of those things and help them through them and train them how to do them, and then they can be done on their own by the patient at home or wherever, where it doesn't draw on their insurance and whatnot. Is there a part of the curriculum that's devoted to ways to deliver that? Because obviously one of the big things is you can't control. We see that this is mirrored in research as well as in a clinical setting. You can't control what the person does when they're away from you. You barely control what they're doing when they're with you. So are there aspects of the doctorate level education of PT that are devoted to this is how we present these things to increase the likelihood that you're actually going to do them when you're on your own?
So the way I interpret the question, make sure I got it right, is there specific content that trains me to be better at convincing you to participate in my treatment? Is that
precisely
right?
Because people are not going to get better. I mean, obviously you can develop as a researcher you can develop ways that interventions will help people alleviate their pain, restore their function. There are ways that you can develop the application of those to get the best result. You can even develop exercises that can be done without any of the fancy things in a PT clinic that people can do on their own. But it seems like the stopgap is getting people to actually adhere to them. So how do you do that, I guess, is my question.
Well, I would say if you're an aspiring PT student, you would have taken some course content that's related, not the complete process of motivational interviewing, but you would have been exposed to behavior change and some of those type of techniques in your, I'm going to call them clinically focused courses or clinically applicable courses. Part of how am I going to develop a home exercise program? How am I going to teach that? How am I going to check on that? So they receive that type of instruction for sure.
Okay.
There's some other content where they will hear about the behavior change, again, related to pain in particular. Joel does some stuff on that, I think. And then when they're working at the pro bono clinic and on their clinical experiences, so that's where a rubber hits the road spot, that they're at a clinical experience working with patients and a clinical mentor who is helping them navigate some of these things. Now, there is probably enough variability that I could say not every person will work with a clinical instructor who is going to say, here's the magic for getting someone to accurately demonstrate what you showed when they come back next week. It's certainly talked about, and then it's also saying this is going to be this is a hard one. I wish I could remember who said it, but if you're with me for an hour 3 times a week, it's something like 2 to 5% of the available time that you have. So it's way more important what you do when you're not here than what you do when you are here.
So we spent a lot of time talking about low back pain, but because of your background, you have collaborated with a number of researchers on a lot of different types of studies. If you go down your CV, there's work funded by the Medical Marijuana Consortium. There are practices that you've investigated as replacement for non-pharmacological to get away from opioid, as you mentioned. You've had a chance to work with a lot of different people on a lot of different projects, not just the ones that you've led yourself. What are some of the more exciting ones? What are the ones that if there was anything that could tempt you into devoting more time to research, what are the ones that have maybe, I guess, generated the biggest questions or the most excitement from you?
I'm going to tell you about 2 that I'm very fortunate to have going on right now, and I'm genuinely interested. That's terrible to say. It makes me think I'm not genuinely.
All the times that you really.
Yeah. So, but I'm excited to say, I can't wait to find out what this is.
Mm-hmm.
So, in one of them, this is a collaboration with Mike Robinson's group again. But, philosophically, if we think that your pain neurophysiology, there's the physiology. If it's a physiological system like other systems, you can probably train it.
Mm-hmm.
And if I think about the last 30 years, I have probably accidentally exposed people to pain quite a bit. It hasn't been my deliberate intent to make you worse, but there have been times where I have made you worse. And so if I think about the pain system, or actually if I think about the cardiovascular system, how do I improve that?
Mm-hmm. Exercise.
Right? I expose it, I stress it, and then I recover.
Sure.
Stress it and recover. And same with other physiological systems. So if pain's a physiological system, I potentially should be stressing it and letting it recover.
Mm-hmm.
But what I have focused on is reducing your pain experience.
Mm-hmm.
If that makes sense. So
yeah.
I'm not stressing it. In fact, I'm going to try very hard not to stress it. And so we have doing some work.
So are you turning your pain system into a couch potato, essentially?
Exactly. Yeah. Exactly. So.
No, I think an important component of that, obviously, at least in the exercise paradigm, cardiovascular system or musculoskeletal system, whatever, and you're intimately aware of this as a PT, is the stress has to be within a certain bandwidth so that it's not something that causes injury, but that prompts adaptation. So is that what he's looking at with?
So.
They, I should say. I'm sure he's not working with
this idea where we can expose you to some clinically relevant stimulus that makes you pause, but then resolves.
Mm-hmm.
And then a bit later on, expose it again and then resolves. And like I said, I probably have accidentally done this to people. I haven't deliberately done it to people.
Mm-hmm.
But so, I'm really excited to see how that happens. And intuitively, when I have talked about this before, intuitively many people can kind of see, it's like training your pain tolerance, or you is what people will say. Or, if you work out regularly or you work regularly, you're going to experience something that's painful, but it's not threatening, and you say, oh yeah, that hurts, but it's not so bad. And so I think there's elements of that, and there's couple of other neurocognitive things.
That's some of the best research, it seems, to, at least from my perspective, is in the areas that we seem to have danced around. Because what you're talking about also seems to be, in a way, central to pain catastrophizing, right? That people who catastrophize over the pain that they're experiencing, the ones that think it's worse than it is or that it's not going to get better, may be those who haven't been in a situation where their pain has resolved. So that idea of inducing pain or exposing a person to pain, but then allowing it to resolve. A lot of, and this is a broad, very non-scientific comment to make, but a lot of the times that we have the greatest fears or the greatest aversions to something is when we don't have the experience of what's on the other side. And so, I'm sure that if you take an athlete like a hockey player, for example, who's had teeth knocked out or broken bones or had to get stitched up in the sin bin or whatever, they're probably less aversive to that level of pain or that level of risk, even physically, knowing that they'll recover from it. And yeah, it hurts, but it doesn't hurt forever, and it gets better. And maybe it really wasn't so bad. And so to look at pain research and maybe pain conditioning from that aspect, I think is really intriguing.
Yeah, I think that aligns pretty nicely, that I can have the experience, live, then have the experience again, and then be able to say, you know what, I will be okay, or this will be okay, or I will recover. And I'm not quite smart enough to know the separation between what is going to be physiology specific changes, but I certainly the way I cognitively and effectively interact with the stimulus is going to be part of that. Mm-hmm. So that's a very interesting.
What's the second?
So, brand new area for me. This is a collaboration with Meryl Alapatu, who's a PT. And she is asking the question about, so if you have gender affirmation surgery because your physical body doesn't match your identity, you're having musculoskeletal surgery. People are having pelvic floor surgeries, mastectomies, facial surgeries. These are extensive surgeries, which in cis people are associated with sometimes disability, but certainly pain. People receive rehabilitation for some of these conditions post-surgically. Not all, but some. And Meryl was wondering, so, why do I not see more people who have had gender affirmation surgery who have pelvic pain or shoulder pain after mastectomy and these type of things? And so she has started looking, and with getting through a scoping review that mostly shows that what's reported is surgical, peri-operative and immediately post-operative, some longer term stuff, but very, very rarely have we come across papers that are focused on musculoskeletal dysfunction. With more recent ones have had incontinence and pelvic floor trouble and prolapse and things. So it's starting to be more commonly reported in the literature, and she's begun interviewing people who have gone through a transition surgery or part of a transition surgery to kind of find out more about their experiences. I don't know if you've ever done qualitative research before. I've done one study in the past and thought, holy cow, I don't know if I want to do that again, because it was a lot of work. All you qualitative researchers out there, if I ever said anything mean in the past, I take it all back, because going through the transcripts of even just a couple of interviews that we have, and coding and theming, coming up with the themes is pretty intense.
We just talked about that, and I apologize because it slips me as far as which episode, who I had on, but we're talking about that, and for everybody that's maybe wondering, quantitative research, you have numbers, and numbers work well into
Big
statistical
spreadsheet.
models, and you can compare differences. In qualitative research, you have sometimes paragraphs of answers, and you can try to, in some ways, direct those answers in the way that you ask questions, but it's just not easy to delineate lines, to make comparisons between groups, and to really analyze those data. It's a lot fuzzier than numbers, and so I can see why that would be a huge headache. We were just speaking of that in a prior episode. But that's really exciting stuff, and I would imagine it's got to be really difficult to recruit for that type of study. One thing that people don't realize is that it's great to conduct this research, but you have to have people who are willing to come forward and be a part of your study. And I think in that specific population, because it's not always well received, are you finding that it's harder to get people, or are they more willing to?
It's been a fairly steady enrollment.
That's fantastic. Good.
Fairly steady enrollment. So that's super exciting. I'm really looking forward to getting a bit more information about that. And then the exciting next step, saying, okay, well, if this is the case, these are some things we can do, and all that kind of imagination part. And then I'm going to chuck a third one in there, talking to a colleague of mine who's at Duke, actually Chad Cook, who does manual therapy research, and playing around with a few ideas of what interventions might look like, and some of those type of things, and going back to a bit more of a clinic-oriented trial.
Excellent. Okay. Well, we don't have very much time left. I can't keep you all day. But I am interested, over the past couple of years, we've hinted at this, and people will have heard in the introduction your roles and what you do now, but now in an administrative capacity. You are in a unique position to direct an already appealing program, or at least an aspect of that program. UFPT is pretty well renowned, and there are a lot of aspects of the program here that draw people from around the country, and I would imagine around the world as well. What are some of the finer points of UFPT that really make this a unique place to answer phone calls and whatnot? To make this a unique place to get that training. So that's one. What makes UFPT such a great place? Because I think we both would agree that it is. And two, what are some of the ways that you want to expand UFPT and make it even better in the coming years? And I know that you're coming out of a position where you've spent at least the freshman component of this new role under COVID. So that's got to created some problems. But
yeah, so. My role is I am the director of the professional PT education program. So the program that awards the DPT. Mm-hmm. We're in a department of physical therapy that also has graduate faculty, graduate students doing PhD work, some training grants and stuff like that. And I'd say broadly at the department level, why am I still here 25 years later or whatever it is because quite literally, there are people with whom I work that are inventing what I will do as a PT in 5 or 6 years. Viral therapies and genetic therapies and all these type of things. I mean, and I tell the PT students when they come in, say, I don't know what to do if someone gets an injection of some type of genetic therapy that's going to be delivered. I don't know what to do to help that person, but the fantastic news is we have other faculty in the department who are working on what you do about that. Mm-hmm. So, that just blows my mind sometimes to say, a bit of a primitive brain over here. I'm clunking along doing my thing, and right over there are people who are working out what we'll be doing in 5 or 6 years, which is crazy.
That's fascinating.
So that I have always loved about being here. And then we have a group of faculty in the PT education. So back to this Doctor of Physical Therapy program. The faculty and staff in there. The faculty, about half, a bit more than half, I think, all have physical therapy degrees. We have some people who have been practicing more recently than I have, so that's good. And we have some collaborators from the community who are practicing now. So I think there's this nice mix of the spectrum of clinical experience that is good. COVID was an interesting time to kind of say, hey, we'll do all these great things, we're going to do awesome things, but the university is closed. Right. And so, dealing with that has been good, but we're getting ready now to start a planning process and say, it looks like it's been a pretty sloggy 2 years and people are tired, but we're going to try and have a planning thing and say, where will we be in the next 3 years? And there's just my opinion. It'd be interesting. This is interesting timing because we'll have our strategic planning at the end of February, start of March. But we can embrace being a traditional program. What traditional? I mean, we're a university-based program. We're on site. We we're not hybrid flex. You live in Wisconsin and fly down once a month to do labs. You come and live in Gainesville. So residential, I think, is and we have people who care passionately about physical therapy as a profession, who are physical therapists, and we have some incredible collaborators in the PT education who are faculty of the department who are making tomorrow's rehabilitation interventions today. And I think everyone cares very deeply about students succeeding. We just all have a little bit of a different opinion about how to get there.
Right.
And so I'm excited because I think if we come together, everyone is so intense about everyone being successful that I think can only be good.
Yeah.
As long as we all get going in the same direction, it's going to be great.
Just as long as the answer to where will we be in 3 years is not, well, we'll still be doing this.
Yes.
we keep talking about when things, are reemergence from post-COVID. So here's fingers crossed.
My mindset, the way I think about it, is that in 1989, when I was working in a hospital, I did not wash my hands between patients. I would wash my hands if they were visibly soiled. If I changed bedding that was visibly soiled. But I didn't routinely do it. I did it mostly. And then HIV, and then MRSA, and a couple of other health conditions changed the way I had to practice. I really think that what COVID might end up is that I will always practice with a mask. That as well as washing my hands, putting on gloves, I'll put on a mask. Maybe that's the end result. And I don't know, it's been 2 years. I'm quite used to going to whatever health provider and they've had masks on for a while. I just think it's going to be like that. The hard part is this social interaction and how we, stay human, if that makes sense, how we keep the humanity in us going. But from a healthcare and a healthcare education, I think we may as well just embrace.
Might just be a next step in the evolution of good practice.
Absolutely.
I have one more thing before we close. This is, relatively unprofessional. I don't mean for it to be superficial, but I'm certain that my Aunt Mickey has been hanging on every single word. So if you would just say a hello to Marquita, I'm sure she would really appreciate that, since I love my aunt so much.
G'day, Marquita. How are you? Mark Bishop here.
Perfect. And with that, thank you so much for taking some time. I know you're very busy, but I've really enjoyed the conversation. Thanks for coming on.
Me too. Thanks for the invite, Mark. It's good.
Thank you for joining this episode of The Price of Pain. Opinions expressed on this podcast are solely those of the host and guests, and not representative of the University of Florida or parent institutions of our guests, unless specifically stated. You can find more information about Price on the World Wide Web at price.ctsi.ufl.edu. And keep up with our researchers on social media by searching Facebook for UF Price, by following @UF_Pain on Twitter, and Price of Pain Podcast, all one word, on Instagram.